Stable angina is predictable chest pain caused by insufficient blood flow to the myocardium and often precipitated by physical exertion or emotional stress. The most common underlying cause of angina is atherosclerosis, where fatty plaques build up inside the coronary arteries. Anginal pain is classically central or left-sided chest pain with radiation to the arm, jaw, or back, and is described as a pressure, tightness, or heaviness on the chest. In stable angina, the pain is relieved within minutes of either resting or after a dose of GTN. If the chest pain occurs at rest or becomes unpredictable, unstable angina or myocardial infarction should be considered. All patients with anginal symptoms should have a full health examination to assess for any underlying cardiovascular risk factors. For instance, their cigarette and alcohol consumption, any presence of high blood pressure, raised BMI, and any heart valve pathologies heard on auscultation. An ECG should also be performed. However, a normal ECG does not exclude a diagnosis of angina. A blood test should be performed to assess for any contributory causes for angina, for instance, anemia or hypothyroidism. Additionally, a blood test should assess lipids and HbA1c to assess for any other underlying cardiovascular risk factors. It is useful to also get a baseline level of kidney and liver function, as these are necessary before starting secondary prevention medications such as ACE inhibitors or statins. All patients should be offered CT coronary angiography, where contrast is injected into a vein and a CT scan is performed to visualize any narrowing of the coronary vessels. This scan should be offered along with more invasive coronary angiography, which remains the gold standard investigation. Invasive coronary angiography is performed in a cardiology cath lab, where a catheter is inserted into a patient's artery, either in their arm or leg, and it's progressed through to the coronary vessels. Once in place, a dye is then injected and X-rays are taken to assess the patency of the coronary vessels. Cardiac stress testing is also a useful tool. A patient will undergo some physical exertion whilst having an ECG or other cardiac function test to assess for any exercise-induced changes suggestive of ischemia. Stable angina should be managed through a combination of conservative and medical treatment options. If persistent or severe, then surgical options may also be considered. All patients should be advised to improve their cardiovascular health, meaning giving advice to stop smoking, maintaining a healthy weight, and to increase their physical activity levels within the limits of their symptoms. Also, encouragement should be given to limit alcohol consumption to within recommended limits. Medication for angina has a few purposes: to immediately relieve the symptoms of angina, along with providing longer-term relief of symptoms, and also to reduce the risk of secondary cardiovascular events. Sublingual GTN spray provides relief for the chest discomfort associated with angina and should be taken when required. If we focus more on the longer-term symptom relief options, NICE suggests that either a beta blocker or calcium channel blocker should be used first line for angina treatment. The choice of which medication to start depends on patient preference, along with any contraindications. A common contraindication to beta blockers is asthma. If a calcium channel blocker is used as monotherapy for angina, it is often a rate-limiting calcium channel blocker, such as diltiazem or verapamil, as these agents have the additional benefit of decreasing myocardial contractility and heart rate. An important contraindication to a rate-limiting calcium channel blocker is heart failure with reduced ejection fraction, as reducing the strength of the myocardial contractility will worsen symptoms of heart failure. If anginal symptoms persist, guidance is to increase the dose of their current medication to the maximal recommended dose. If symptoms still persist, then management depends on what medication the patient is currently taking. If a patient is taking a beta blocker monotherapy, then advice is to add in a non-rate limiting calcium channel blocker, such as amlodipine or modified release nifedipine. If a patient is taking a non-rate limiting calcium channel blocker as monotherapy, then advice is to add a beta blocker. If a patient is taking a rate-limiting calcium channel blocker monotherapy, such as verapamil, then do not add a beta blocker, as this can cause heart block. Instead, consider switching to a non-rate-limiting calcium channel blocker and then introducing a beta blocker, or consider the use of a second-line anti-anginal medication, such as a long-acting nitrate, nicorandil, ivabradine, or ranolazine, although it is advised to seek specialist advice if considering starting ivabradine or ranolazine. If established on dual therapy with worsening symptoms, then a cardiology referral is warranted to assess for revascularization. Surgical options for the cardiology team are either percutaneous coronary intervention, PCI, with angioplasty and stent placement, or coronary artery bypass grafting, CABG. This is used for more extensive or complex coronary artery disease. Short and medium-term outcomes for either procedure remain similar. However, PCI is noted to have a faster recovery and lower rates of stroke as a complication. However, patients having undergone PCI tend to need a greater number of repeat vascularization procedures. It is worth noting that all patients with angina should also be started on medication for secondary prevention of cardiovascular events. This includes an antiplatelet, aspirin 75 milligrams, and also an ACE inhibitor. If indicated, lipid-lowering medications such as statins should also be started. So when should patients be referred to the cardiology team? As mentioned, if symptoms are refractory to dual therapy, or if symptoms appear to be progressing towards unstable angina in a rapid fashion. This means either the severity of the chest pain is worsening, or if the length of recovery after rest or GTN spray is becoming longer. Remember that all patients with angina should be advised to rest and utilize their GTN spray if an angina attack comes on. If the patient has ongoing chest discomfort 5 minutes after the first dose of GTN, they can take a second dose of GTN. If 5 minutes after this second dose they still have chest pain, the patient should contact 999 immediately. If you'd like more information about any of the lifestyle factors discussed, or for a deeper look at any of the medications used in angina, then please take a look at my other videos on YouTube, which are also available in podcast format. Just search for Dr. Dan wherever you get your podcasts from. Anki flashcards on stable angina are also linked in the description for you to download and aid your revision.